So good afternoon to all of us, and we are welcome to this week's presentation on peripheral vascular disease. We are playing emphasis on peripheral arterial disease today. It's quite a common disease that is usually overlooked. I'm sure we will learn a thing or two from Dr. Evans as he takes us through this presentation. A few housekeeping issues. If you want to ask a question during the course of his presentation, kindly make use of the chat box. And at the end, we can have a discussion around it. Please keep your microphones muted. You realize that when you join, you're automatically muted. If you need to talk at the end of it, we'll allow you to do so. Without much ado, I would invite Dr. Evans to take us through this presentation. Dr. Evans, please go ahead.
Thank you very much, boss. Good afternoon and welcome to today's presentation. My name is Dr. Degbor and I'm with the Internal Medicine Department of the Upper West Regional Hospital. Today I'll be presenting on peripheral vascular disease. Now, peripheral vascular disease is a terminology that is used to refer to peripheral arterial disease that is caused by atherosclerosis. In some literature, the disease entity is referred to as atherosclerosis obliterans, which translates to obliterative atherosclerosis of the arteries. Here is a pictorial concept of the disease process. And what happens essentially is that there's a buildup of fatty substances in the lumen of the arteries that leads to narrowing and then subsequent diminished blood flow. Going forward, this will be the outline of the presentation. I'll make some introductory statements. We'll look at the epidemiology, risk factors, pathophysiology, clinical presentation, how to make a diagnosis, management and preventive measures, the general prognosis, and then my references. Peripheral artery disease is a clinical disorder where there's narrowing of arteries outside of the cerebral and then coronary circulation. That's outside of circulation in the brain and then in the heart. And the arteries that are commonly implicated are medium to large arteries of the neck, like the carotid arteries, the brachial arteries of the arms, the abdominal aorta, and then more commonly arteries of the lower limbs, mainly the iliac arteries, the femoral arteries, popliteal, and then tibial arteries. The narrowing or stenosis is one that is caused by atherosclerosis and leads to diminished tissue perfusion distal to the point of narrowing. As a result of this, patients will present usually with a clinical syndrome that ranges from an asymptomatic or symptomless presentation to one of intermittent claudication, which is the most common symptomatic presentation, where there's exertional leg pain that is relieved on rest. And then when disease is extensive or far in progression, they present with a condition known as critical limb-threatening ischemia, where these patients will experience pain even without walking. At rest, they are experiencing this pain, which doesn't respond very well to analgesics. Peripheral artery disease is the third leading cause of atherosclerotic morbidity, following coronary heart disease and then stroke. The prevalence ranges from an approximate 5% in people who are in the fourth decade of life, all the way up to between 12 and 15% in people 70 years and over. Globally, there's an estimated 238 million people who are living with various degrees of this disease. And majority of them, about 70% of the time, they are found to live in low to middle income regions of the world, like Southeast of Asia, Eastern Europe, and then Sub-Saharan Africa, of which Ghana is part. The presence of peripheral artery disease is a significant marker for cardiovascular mortality. That is to say, when you have peripheral artery disease, you have a significant risk of getting a coronary artery disease as well as a cerebral disease because of the shared risk factors amongst all these diseases, which are all cardiovascular diseases. The most important risk factor here, according to research, is cigarette smoking, which is considered an independent risk factor for the development and progression of the peripheral artery disease. This is because smoking tends to exert a direct effect on the vascular integrity and then endothelial lining by producing oxidative stress that leads to endothelial damage. And it is when the body is trying
Hello,
to...
sorry. Hello?
Yeah, hello. Please, can I continue?
Please do. Please continue.
Okay, thank you, boss. And it is when the body is attempting to heal the endothelial damage that the whole process of atherosclerosis begins. Diabetes is also considered an independent risk factor for the development and progression of the disease, particularly when diabetes is poorly controlled or not controlled at all. This is because of the macroangiopathic effect diabetes has on the vascular integrity. Other comorbidities like hypertension, especially when it is also not controlled, is known to accelerate the process of atherosclerosis, and also it's another independent risk factor for the development of cardiovascular morbidity and mortality. Hyperlipidemia or elevated levels of cholesterol, usually low density lipoprotein, which is termed the bad cholesterol, and then low levels of high density lipoprotein, which is termed the good cholesterol, are also risk factors for the development and progression of the disease. People who are overweight, obese, and have sedentary lifestyle are also at risk of developing this disease. And alcohol, especially if it's taken in excess, is known to accelerate the development of hypertension and then subsequently the development of cardiovascular diseases, of which peripheral artery disease is a part. Dietary imbalance, where there's excess consumption of junk food, fats and oils, and particularly carbohydrates, is also another risk factor for the development of metabolic syndrome as well as peripheral artery disease, because excess carbohydrate is usually converted to fat and then will escalate the whole process of the disease. Age is another important risk factor because the longer that you stay in the world, the better or the higher your chances of getting what the world has to offer, which includes all the good things and then all the diseases as well. When it comes to the pathophysiology of peripheral artery disease, it is one that largely centers around the development of atherosclerosis. And atherosclerosis is defined as a progressive, insidious, inflammatory disorder of the arterial wall that is characterized by deposition of cholesterol plaques, which leads to arterial lumen narrowing. Commonly, it is occurring at the arterial bifurcation points or arterial branch points, where generally the blood flow in these areas is high. And as a result of that, there's an overall increased shear mechanical stress in these points of the arterial vascular tree. So the presence of this coupled with ongoing and poorly controlled risk factors like smoking and the metabolic syndrome leads to endothelial damage. And once there's endothelial damage, what happens is that the endothelial cells express certain receptors that attract inflammatory cells, mainly monocytes. So these monocytes infiltrate the site, and in an attempt to heal the endothelial injury, they react with oxidized low-density lipoprotein to form macrophages that are lipid-laden. And these lipid-laden macrophages are essentially called foam cells, which are poorly resolved when they die. So they secrete certain cytokines, particularly interleukin-1, tumor necrosis factor alpha, interferon gamma, and then platelet-derived growth factors that are intended to promote the healing of plaques by stimulating the migration of smooth muscles from the media of the artery all the way to the endothelial layer. And the idea is they are supposed to heal, let's say, the patches that are formed by this oxidative damage. But once they do this, they begin to cover the lipid plaques or the lipid-laden macrophages that are not easily resolved into the system. So this process is gradual and ongoing until there's significant amount of smooth muscle cells covering and burying these plaques into the arterial walls. So the plaque continues to stay in this buried smooth muscle cells and continues to grow until a time where it is large enough to cause significant occlusion that will present with clinical signs and symptoms. Atherosclerosis is known to begin early in life, usually in the first decade, but will not show because of the slow and progressive nature of the disease progress until about the fourth decade and beyond, where it may begin to show in some people. Here's another schematic that is showing the sequence of progression of atherosclerosis in the first decade as the first two segments of the arterial wall. This is a cross section. You notice that it looks almost normal, but then there's gradual deposition of fatty streaks, and then eventually there's gradual deposition of fatty pools. But because of the constant efforts of the body to heal these plaques, they continue to cover with smooth muscle cells until a point where the plaques are big enough to cause a significant occlusion. By this time, the smooth muscle layer, which is usually a fibrous cap, has lost its integrity. And when there's coexisting risk factors which are not well controlled, it can lead to erosion of the fibrous cap. And then finally, there will be rupture of the plaque, exposing the lipid core to the bloodstream. And when this happens, there's aggregation of platelets to the lipid core, and this forms a thrombus, essentially what is called a blood clot. And this blood clot, if it's large enough, can form a total occlusion of this artery and then lead to significant clinical presentation. But most of the time, the thrombus that is formed or the blood clot that is formed is not strong or stable enough. So sometimes it can be dislodged and then cause embolization at a distal occlusion in another artery down the line in vascular tree. Atherosclerosis follows an anatomic pattern, and then the symptoms usually depend on the location and then severity of the disease, where the severity of the disease has to do with how many lesions are present on the vascular tree, as well as the degree of narrowing. Primarily, the most common sites of involvement are the femoral and then popliteal arteries in about 80 to 90% of patients. So these patients, when they have symptoms, will usually present with calf pain classically, where they walk for a while and then they experience the intermittent claudication or the crampy calf pain that comes with exercise. For about 40 to 50% of patients, we have tibial and peroneal arteries involved, whereby these patients will have more distal clinical presentations like pain in the toe and then the distal end of the foot. In aortoiliac arteries, which is found in about 30% of patients, presentations will be higher up around the hips and the buttocks and then the thighs. And particularly in men, sometimes they present with a syndrome known as the Lerich syndrome, which is a triad of claudication, diminished or absent pulses, and then erectile dysfunction. The clinical presentation of lower limb ischemia comes in two distinct clinical entities. The more common one being the intermittent claudication, where there's exertional pain that is relieved on rest. And then a much more advanced disease, which is called the critical limb threatening ischemia. Patients have pain at rest that doesn't respond to analgesics. Sometimes they may also develop ulcerations, and when these ulcerations are infected, they also form gangrene. And these ulcers are usually difficult to heal because of the diminished blood flow to those areas. When symptoms of critical limb threatening ischemia are less than 2 weeks, we consider it an acute incident. And when it's more than 2 weeks, then we consider it a chronic limb threatening ischemia. When we want to evaluate a patient at risk for peripheral artery disease, we begin with a clinical history where we try to establish the presence and duration of the risk factors, namely the smoking, amongst others. We also use this chance to review the symptoms of the patient, the duration, the kind of symptoms the patient has, and then how severe they are and how they affect the patient's life. We conduct a general examination as well as a cardiovascular physical examination where we pay more attention to the pulses of the patient to see if we can pick up any diminished or absent pulses. We can pick up any bruits on auscultation and any other physical signs and symptoms on the patient's lower limbs. Then to make a diagnosis, we use a simple in-office assessment known as the ankle brachial pressure index, where we measure and compare the BP at the ankle of the patient compared to the BP at the usual place where BP is checked in the upper arm. For signs and symptoms of claudication, which is the most common presentation for patients with peripheral artery disease when they have symptoms, it's usually a crampy dull leg pain that is associated with exercise and relieved on rest. So classically, a patient can tell you that they used to walk a certain distance, but now when they are walking for a while, they experience this pain that causes them to sit. And when they sit down for about 10 to 15 minutes, the pain is resolved completely before they are able to continue their walking. And commonly, like I said in the previous slides, the calf muscles are affected because of the predilection for femoral popliteal arteries. Other regions I've mentioned in the previous slides are listed below. For critical limb-threatening ischemia, this is a more advanced or extensive arterial disease, and the main presentation is constant pain at rest, which doesn't respond to analgesics, usually in the forefoot and then the toe areas. Sometimes you can pick up skin changes like darkening of the extremities around the toes and the foot, and then sometimes pallor, especially when the patient elevates the limb. Because of the anti-gravity effects, when they elevate the limb, blood is not able to get there. And then when they make the limb dependent, then blood flow through the effects of gravity makes the limb look more reddish, as if there's more blood coming to it. We also have some clinical signs like severely diminished or absent pulses, coolness of the peripheries, especially distal to point of occlusion. We can also have alopecia or hair loss in areas that are supplied by blood vessels that are completely narrowed. And then sometimes we can pick up muscle atrophy because patients, as a result of the pain, do not want to walk anymore. So gradually they tend to lose the muscle function and muscle mass in those areas. We also pick up nail changes where there's brittleness of the nails. The nails are easily breakable because of the decreased amount of blood flow and nourishment that gets to them. And in some cases, depending on the severity, like I said, we can have ulcerations and ganglion formation, mostly in the toes and then the distal end of the foot. To make a diagnosis, we have diagnostic investigations that we use, mainly the ankle brachial pressure index, which is a ratio of the systolic BP, the higher systolic BP measured at the ankle to the systolic BP at the brachium. And normal physiologic ranges are considered to be between 1.0 and then 1.4. When we have values of between 0.9 and 0.99, this is termed a borderline peripheral artery disease. And before you can confirm that a patient has peripheral artery disease, you have to do further investigations coupled with the presence of clinical symptoms. Now, peripheral artery disease is diagnosed when the ABPI is less than 0.9 in a symptomatic patient. And when there's severe PAD or critical limb-threatening ischemia, we make a diagnosis when there's symptoms and then we have a value of less than 0.5. Another diagnostic investigation we use is the duplex ultrasonography of the arteries. And what this does is that it's able to locate areas of narrowing in the arterial tree and areas of diminished blood flow, which confirms that these are the areas where atherosclerotic plaque formations have formed. Supportive investigations to pick up other cardiovascular diseases include full blood counts, lipid profile to know the level of the cholesterol, liver and renal function tests, as well as non-specific inflammatory markers like ESR, C-reactive protein, and then an ECG to pick up any cardiac-related or coronary symptom disease. We can also do X-rays of the lower limbs, and where there's extensive disease and prolonged disease, sometimes the atherosclerotic plaques become calcified, and then you can see them on X-rays as hyperlucent areas along the vascular tree. And then in much more advanced diseases, which usually will require surgical intervention, that's when we employ the use of CT angiography and then MR or magnetic resonance angiography. When it comes to management of peripheral artery disease, the aim is symptomatic relief and then to lower the general risk of cardiovascular disease progression and then the complications that arise from it. We employ medical and then surgical treatment modalities include non-pharmacological therapy, which is mainly centered around risk factor modification, and then trying to do away with the various lifestyle habits that predispose to this disease. And then we employ the use of pharmacological therapy, where we give medications that can improve symptoms and then improve walking distance as well. And also some medications to prevent thromboembolic events. The risk factor modifications are preventive measures that include smoking cessation. As I said in previous slides, smoking of cigarettes is considered an independent risk factor for the development and progression of this disease. So it's very important that we get patients who are having this disease and who are smoking to quit, because quitting of the smoking has shown that it reduces adverse cardiovascular events and then the risk of amputation or limb loss to amputation or ulceration. It also improves the general walking distance. One thing about smoking is that it's very addictive. So it's always important that when a patient is known to smoke, we treat it as a different or an isolated clinical entity, sometimes having to involve the clinical psychologist to counsel them. Because when you tell a patient at the OPD or on the ward that they should stop smoking, maybe out of the anxiety, they'll even get home and then they'll light a cigarette just to forget what you've told them about the chances of them losing their limbs if they continue smoking or they continue in that pathway. So sometimes to control the nicotine addiction, we employ the use of nicotine gum or nicotine patches, which will gradually reduce the dependency on cigarettes and until a time where the patient is able to wean off completely. Another risk factor modification we employ is supervised exercise therapy. And this involves asking the patient, supervising the patient to have daily exercise, which includes walking of up to 45 minutes a day. And we are encouraged that the patient is encouraged to walk until a point where they feel the pain, then they rest, and then after the pain subsides, they continue to walk again. This is known to induce angiogenesis and creation of collateral blood supplies or additional blood supply to the affected muscle groups. We also involve the dietary department or dietary consultations to modify a patient's diet so that we can wean them off eating imbalanced diets, junk foods, and then bring them closer to much more balanced foods and then improved standards of eating. We also encourage people who consume alcohol to cut down intake or stop completely if they are able to do so. For pharmacological therapy, we give certain medications like cilostazol, which we use in Ghana here as well, with doses between 200 to 250 milligrams 2 times a day. And this medication is known to cause vasodilation as well as inhibit platelet aggregation. So this generally will improve claudication, walking distance, and reduces the pain as the patient walks. We also use antiplatelet therapy, and the general recommendation from standardized research is that we use a single agent antiplatelet like aspirin, clopidogrel, or ticagrelor to reduce the risk of cardiovascular diseases like thromboembolic events like a stroke or a myocardial infarction. Then we also give lipid-lowering medications that will reduce your total cholesterol, and in the form of statins like simvastatin or atorvastatin. And the recommendation is to give moderate to high doses of this medication for all patients who have been diagnosed with peripheral artery disease. For those who have comorbidities like hypertension, the first line antihypertensive that is recommended is the ACE inhibitor like lisinopril or ramipril. But these medications tend to have side effects like a dry cough. So when patients are put on this and they are not able to tolerate it, then we switch to angiotensin receptor blockers like losartan or valsartan. For those who also have diabetes, which is an independent risk factor for the development and progression of this disease, the first line medication that is recommended is a sodium glucose co-transporter 2 inhibitor. And what it does is that it reduces the renal threshold for glucose, and then the patient is able to lose what we call it, glucose in their urine without need to alter insulin in their body. Some of these medications are dapagliflozin or canagliflozin. When we come to surgical therapy, usually this is reserved for patients who have severe disease that is causing them lifestyle limiting claudication. Maybe this person is still working, this person is still productive in society, but because of the degree of the severity of the disease, which is not responding to medical therapy, we tend to employ surgical interventions. And some of them are the balloon angioplasty and stenting, and this is done by a vascular surgeon, where a balloon catheter is inserted in the narrowed part of the artery, and then it is inflated to widen it. Once it is widened, a stent is placed, the balloon goes in with the stent, and once it is widened, the balloon is deflated, and then the stent is left in place so that it forms some form of, a reinforcement of the vascular wall to prevent a collapse or narrowing after you've inflated it. Another procedure that we do is the bypass grafting, which is a surgical procedure once again performed by the vascular surgeon to redirect blood flow around the area of blockade. So sometimes they use the patient's own vein from another part of the body, maybe the saphenous vein, or we employ the synthetic material to cause this diversion of blood flow to the affected muscle groups. And then another surgical intervention is the percutaneous or laser atherectomy, where a catheter is inserted, which contains sometimes a blade, a very sharp blade, or a laser. And generally, the principle is that it grinds down the atherosclerotic plaques from the vessel, and then they have a collecting system that picks up the debris of the plaque that is broken down to prevent embolization at further or different areas of narrowing. The prognosis is generally good if treatment is initiated early and then risk factor control is optimal. The natural history of patients with peripheral artery disease is influenced by the primary extent of coexisting coronary artery disease and then cerebrovascular disease. This is because of the continuum in the vascular tree. So if you have an existing stroke or an existing coronary artery disease, and then you have a peripheral artery disease, your general risk of survival in 5 years is seen to be around 15 to 30%. And life expectancy is usually difficult to determine, but research suggests that 1 in 5 people who have peripheral artery disease will suffer from a heart attack or death within 5 years if they do not seek treatment or optimal treatment. These are my references from Medscape, Harrison's Principles of Internal Medicine, Davidson's Up to Date, and then some Google images. Thank you very much for your time.
Thank you very much, Dr. Evans, for an excellent presentation. That was very concise, straight to the point, and definitely highlights all the points regards peripheral artery disease and the various things that we should look out for. It's been a learning one for me, and I'm sure a lot of our participants would have learned one thing or the other. Just before we go on to the question and answers and comments that people may have put in the chat box, if you take a look at the chat box with me, you realize I just put in a link there. If you need the slides to this presentation, kindly click on that link, provide your responses towards evaluating what we have done today, and then you would provide your email where the slides will be sent to you so that you can go through at any time that you want. So if you need the slides, just click on that link, provide your responses. And then at the end of it, you see that there's one that asks you to put your email address in for the slides to be sent over to you. So out of the brilliant presentation is done, I guess we'll have a couple of discussion points around it. First, we'll look at the chat box to see if there are some questions in there. Yeah, so a few of them. Dr. Betty is asking, please, the ankle breakup pressure index, is it with respect to specific limbs on the same side or is on different limbs? Dr. Evans, you want to help us with that?
Yeah, sure, boss. I haven't come across any specific limb to use, but I think the general thing is to do it in both areas, both the left and then the right, so that you can have objective values at the end of your examination.
Yeah, so obviously, usually you do it like he said, you do on ipsilateral side comparing the pressure in the ankle to that of the pressure in the brachium. Usually what you take is actually the highest systolic readings and compare both. And then you go contralaterally to do the same on each side. So definitely that's the response to that question. Dr. Emmanuel Chunibwa is asking, he's saying that thanks for the presentation. Please, which of the antiplatelets is the preferred first choice? So the antiplatelet therapy, Dr. Evans, which is preferred as first choice?
The first choice is usually aspirin or clopidogrel, from what I'm aware.
Yeah, so I agree with you on that. It's either aspirin or clopidogrel. Most of the guidelines do not agree with the dual antiplatelet therapy, except, of course, on a case-by-case basis. But in terms of comparing aspirin versus clopidogrel, there was a multi-center trial called the Capri trial. I'm sure Dr. Chuniboy is a resident. I'm sure you'll be interested in trials. So you could take a look at that. It's called the Capri trial. And when that was done, clopidogrel had a modest advantage over aspirin in regards reducing the cardiovascular risk and risk factors of ischemic stroke and all of that. However, comparing ticagrelol, which was the third agent he mentioned, of course, ticagrelol is also available now in Ghana. Comparing that to clopidogrel, actually, there wasn't any significant differences. The cardiologist, I'm sure on the platform, would quickly add that usually ticagrelol provides additional benefit for preventing cardiovascular events. But in terms of PAD, there wasn't any significant differences in the two. So preferred first line than platelet therapy, single agent clopidogrel or ticagrelol. Soluble aspirin also suffices. So the next one is from Amina Mohammed. She says, great presentation. Betty also says same. I can't agree any less with them, Evans. There's Steve, I'm sure probably that's Dr. Blankson. He says, great presentation. Please, what the differential diagnosis should we be looking at when patients present with claudication? How do we differentiate between a neurogenic claudication from a peripheral artery disease? Dr. Evans, do you want to help us with that? The differential diagnosis of PAD.
Some of the differential diagnoses I know are diabetic neuropathies and then diabetic foot ulcers, especially when there's ulceration from peripheral artery disease. I also know of Berger's disease or thromboangiitis obliterans. There's also Raynaud's phenomenon, and that's what I can remember currently.
Okay, great. How about in terms of differentiating neurogenic claudication from the, what do you call it? The vascular claudication that you have done, as in peripheral artery disease. Any specific differences that we should be looking out for?
But not that I can think of currently.
Okay, so typically, usually, those are two things that you have to look at, regards whether it's a nerve entrapment, what is referred to as the neurogenic claudication, or you are looking at an arterial blockade, arterial insufficiency, referred to as a vascular claudication, like you have said. Clinically, usually there are certain things that may help differentiate between the two. So typically the pain, like you described, goes more for the vascular one. It's a crampy kind of pain versus when you see the radicular pain in the case of a neurogenic kind of claudication. Again, typically with the neurogenic one, because it follows a certain nerve kind of thing, especially with the lumbosacral one, you tend to have that one like the sciatica. The pain with regards to claudication will be in the muscles that are exercised, so the calf muscles and all of that. And relief of the pain once you rest, the one due to vascular claudication would be reduced. However, if it is with neurogenic, when you decrease the stretching on the nerves, like the physiotherapy people always say, like flexion posture and or sitting, you tend to have less of the pain. Again, the pulses, like we have demonstrated, either by the ABI, would definitely be reduced as compared to normal pulses in a nerve root entrapment, like in neurogenic claudication. I think out of that, the other things are usually the diagnostic things, like whether you are using a myelogram in the diagnosis of the neurogenic claudication, or a CT scan or MRI, which may give you what the entrapment is. But these are definitely normal if it is as a result of a vascular claudication. I hope, Steve, if that's Dr. Blankson, this helps differentiate the neurogenic claudication from a vascular claudication or vascular insufficiency due to a PAD. Dr. Emmanuel Chunibo says, thank you. Kona Tetae says, thank you. Bonyela Ahmed says, so awesome. So these are all the messages I have in there. Please, if you have any question, kindly just unmute yourself and go ahead. Or if you have an addition, you are free to do a search or any edits a search. Please feel free, you could go ahead to unmute you put up your hand so that then I can allow you to unmute yourself, because I think some people inadvertently were unmuting themselves and preventing us from continuing the presentation. So just kindly raise up your hand, I would unmute you to go ahead with your question. Let me allow you to unmute yourself. Yeah, so I've also clicked that you are allowed to unmute yourself. So you could just unmute yourself and go ahead with any question that you have. I think we'll be able to do this in 30 minutes. Dr. Evans, excellent job done. Any questions? Kindly put up, just unmute yourself and go ahead if you have any question. There are some 2 comments in the chat box. Huawei P30 says, thank you, great presentation. I think those are all that we have. Kind reminder again that there is, okay, so I see 2 answers. Dr. Opong, please, you can go ahead. Kind reminder that in the chat box, there is a link in there. Just click if you need the presentation. We'll send it over to you. Dr. Opong, please go ahead. Hello? Dr. Pong, can you hear me? Dr. Evans, can you hear me?
Yes, boss, I can hear you.
Okay, then I guess maybe Dr. Pong's micro.
Dr. Evans, you got a great presentation. Yes, boss, I can hear you.
Okay,
yeah, hello, boss.
Yes, please go ahead.
Yeah, so Dr. Evans, you've done a great presentation. I would like to know more about the Lyrich syndrome. That's the first question. And then, do we have any, as in people with peripheral vascular disease and then coming with erectile dysfunction?
Dr. I struggled to hear you. I don't know if Evans got your question. Dr. Evans, did you get what he was asking, or he's asking?
But I couldn't hear the second one.
Okay,
Yes,
Dr.
I was
Okay, so
talking about Lirich syndrome.
Rich, okay, okay, yeah.
More like it. And then
Yeah.
secondly, I asked if those who come with erectile dysfunctioning, can you throw more light on the relationship between erectile dysfunction and then PAD?
Great. Yeah, all right, that's clear now. Dr. Evans, please, do you have any responses?
For the first question, Leriche syndrome is a progressive disease that will present with the classic claudication, erectile, and then decreased or absent pulses. And then it's also, because the cardiovascular disease, it also has similar risk factors like the peripheral artery disease and then coronary artery disease and then the cerebral diseases as well. The way to diagnose is just similar to the peripheral artery disease. So when a patient comes with this, with erectile dysfunction, I think it's prudent to ask about other things leading to peripheral artery disease in terms of risk factors. And also, if the patient coming to you seems to be somebody who has comorbidities like hypertension, diabetes, then we can be looking in the direction of Leriche syndrome if they are presenting primarily with erectile dysfunction, because that's something that a lot of people will come as an isolated presentation, ignoring the other things that are happening to them. And boss, the second question, I still don't get it.
Yeah, I think you was asking about erectile dysfunction.
Okay.
PAD.
Boss, then I think I've answered it in the first one.
Okay. Dr. Pong, are you okay, or you would want to talk any further? You can mute yourself and go ahead. So, of course, the lyric. Okay, yes, go ahead.
Yeah, so the Lewis syndrome, well explained. I know it's three parameters that I wanted to hear him say. And he has mentioned them: the intermittent claudication, the impotency, and then of course femoral pulse absence. That constitutes the Lewis syndrome. I think it's well explained. But the erectile dysfunction, because I read somewhere people with PAD usually come with erectile dysfunction. But the physiology behind that, which I don't know, and which I needed more explanation. But I think I'll read on it.
Yeah, so with what do you call it? Peripheral artery disease, obviously. Hello? Yes, can you hear? Can you hear? Dr. Bong? Yeah, I guess probably his network may be a bit problematic, but like Dr. Evans said in his initial, his introductory remarks, obviously the pain or the pathology with peripheral artery disease corresponds to the anatomic site. So obviously, if you have the PAD involving where what is needed to
yes, please,
then definitely you tend to have.
Yes, I can hear, boss.
Okay, so the main thing is what I've seen in the literature is regards to bilateral to iliac peripheral artery disease. That usually they say that when it's severe enough, it may cause some lower extremity symptoms, which are almost always related to erectile dysfunction in men as well because of the iliac occlusion. So this is what is in literature, and typically that usually comes under the buttock and hip claudication if you are looking at with regards to peripheral artery disease. So that's the link between erectile dysfunction and peripheral artery disease. Obviously, you need blood flow for you to have a sustained erection. Is that also? So if you have compromise of the iliac vessels with regards to peripheral artery disease, you can tend to have that. I hope that that's justice to your question. Okay. I think Dr. Hot 8 says great presentation. Emmanuel Chuniboa, please, how early after diagnosis will you refer a patient to see the vascular surgeons? Okay, Dr. Evans, regards the surgical treatment. When do we, yeah.
like I said, for surgical therapy, we usually reserve it for people who have severe PADs that is affecting their daily lives, especially when these people are not responding to treatment. That's the point where, as soon as possible, if they can meet a vascular surgeon, then it's advised that you refer them with all that you've done so far up to that point for them to see the vascular surgeon.
All right, great. So usually, of course, like you said, definitely want them to be assessed earlier than not until we don't want to wait until you tend to have a what do you call it, irreversible or critical limb ischemia. So it's definitely a good thing to usually send them in for assessment. Referral to the surgeon usually doesn't necessarily mean that they will start the surgical intervention. All right. I saw another hand up, but I think the person has lowered the hands. If you were answered, then that's fine. Otherwise, if you want to put up your hand, you don't even need to just unmute yourself and go ahead. Okay, kind reminder again that in the chat box, you find the link there. If you need the slides, just click on it and provide your responses and your email address, then we can send that over to you. I don't see anything in the chat box. I don't see any hands up. Okay, I guess we did a great job today. We just want to say a great thank you to Dr. Evans for this excellent presentation. We all learned a lot regards peripheral artery disease. It is not so uncommon, especially in the developed world. They tend to have a lot of that because they are, like Dr. Evans put it in a very jovial way. If definitely you would live longer, you live long enough to have a peripheral artery disease, because usually after the age of 40, there are things that can come up, and where you tend to have an aging population, especially in the developed world, definitely that is a growing clinical problem. We don't tend to see so much of it, but it is there, especially now with regards to the non-communicable diseases that we have. And you saw the risk factors he put up. So let's be on the lookout for it. It's not all pain in the limb that is just as a result of trauma. It may be a claudication. And so please look out for it, because it is an adverse cardiovascular risk factor. And so we need to sort this out. When it's identified early, there's medical treatment for it, and we can prolong people's lives. So I want to say thank you to all those who are able to join us today for this presentation. And a big thank you to Dr. Evans for an excellent job done. We would meet again, I'm sure, in the coming weeks with another presentation. Please take care. God bless, and bye-bye.